names, recognize some of the faces. And I'm very happy to be back with you all. So thanks again for taking time out of your evening to be here. So this talk is called, and actually for those of you who weren't around the last time I gave this talk, I'm Andre Mansour. I'm one of the internal medicine hospitalists at Oregon Health and Science University here in Portland, Oregon. And, I really, a couple of the passions of mine in medicine are diagnostic reasoning and also physical diagnosis. And oftentimes they go hand in hand. And so I actually just made this talk. It's very new. I gave it for the first time last week. So hopefully you will enjoy it. The talk is called Physical Diagnosis Potpourri. And basically it's a collection of cases. There are actually 15 cases in total where physical examination was critical in making a diagnosis. And in some cases, the diagnosis was made after a long and circuitous sort of diagnostic adventure to reach the diagnosis when a physical finding was right there waiting to be discovered and wasn't discovered and would have prevented the patient from unnecessary suffering for weeks and in some cases many months. And also the cost of just all this unnecessary testing and diagnostics that were sent off. And all they had to do was discover this one physical finding. So that's what the nature of this talk is about. And you'll notice that I have a picture of a detective here, and that's because I always liken internists and internal medicine clinicians to detectives. Because like detectives, we have to go to the scene of the crime, and we have to pick out the clues that are there. We have to find the clues, whether it's the history or the physical examination. We have to find these clues to make the diagnosis. Patients don't show up with signs saying, I have an S3 gallop, listen right here. They don't do that in real life. So like the detective, we have to go to the scene of the crime and we have to extract that information and identify that information. A physical exam is a big part of that. So the first case, and actually before we get to the cases, I just want to thank all the patients that have allowed us to record, whether it's their heart or take an image of their skin, or a video of their neck. We really want to thank them all for allowing us to do that for educational purposes. So let's go to case number one. And by the way, this is going to be a very interactive talk. And I remember this group was quite participatory last time we did this, so I'm not worried at all. But please feel free to use the chat box or unmute yourselves if you prefer. And I'm going to be answering or asking questions rather throughout the talk. So go ahead and use the chat box to answer those questions. You can also anticipate, because this is going to be each case. I'm going to show you images or audio or video. So if you see something, I'm going to ask you what findings you see in these images. So just go ahead and start typing away as soon as you see the image or think you see something. The history is going to be very minimal, like this. So it's a 46-year-old woman coming in with fatigue. And here are some images of her face and her hands. And that's right. Belen is absolutely right. It's palmar erythema there, which is a bit of a misnomer. So when we think about palmar erythema, the name implies that the palm is red, but in fact, in reality, the palm is often spared, or it is spared. And the erythema involves the thenar and hypothenar eminences, as well as the base of the fingers and the pads of the fingers, just like in this case. So this pattern is classic palmar erythema. There's scleral icterus. Absolutely. We think about the colors in patients. And when patients tend toward a certain color, it can tell us a lot about what's going on with them. If they tend towards blue, they're cyanotic. That tells us that there might be a presence of a right to left shunt or some other cause of hypoxemia. This patient is tending towards yellow, which gives us a clue. And there are telangiectasias, and this is a specific type of telangiectasias on the chest here. These are called spider angiomas. Exactly. Why are they called spider angiomas? Well, they look like a spider. You've got the central arteriole, and then you've got these other capillaries kind of radiating out that look like spider legs. This is a different patient with the same finding. So let's play this video. And you'll see that I'll compress the lesion here, and when I let go, it fills from the inside out. You see that? That is a telltale sign of a spider angioma. It's the only lesion that does that. So here it is in slow motion. Watch how it fills from the middle out. Do you see that? So we have a patient with, so far with scleral icterus or overall jaundice, palmar erythema. She has spider angiomas, and she's also complaining of a distended abdomen. So you examine her abdomen, and we're going to watch a video where it's narrated. and we're gonna percuss the abdomen, and hopefully the sound comes through. Mario, maybe you can give me a thumbs up or a thumbs down if you don't hear the sound. I'm gonna play the video, okay?
So, to panic, dull. Let's have you roll this way. To panic again, so that's shifting dullness. Great.
So we have shifting dullness, which indicates the presence of ascites. So here are all the clinical findings in this case. So what is the diagnosis here? And this is not a trick question. I'm not trying to fool you. So if it seems obvious, it is. What's the diagnosis? Perfect. Cirrhosis. Absolutely. And I started with cirrhosis in part because it's so common, something that we see all the time. And while these findings in this particular case may not have been critical in making the diagnosis, it is sometimes critical when patients come to us with a diagnosis of cirrhosis and they don't have these findings. The absence of palmar erythema, the absence of spider angiomas, the absence of jaundice, that should make you think that it should make you at least question the diagnosis. And there have been several cases over the years that patients coming to me with cirrhosis and they don't have these findings and they ended up being diagnosed. The real diagnosis was constrictive pericarditis or heart failure that was mimicking cirrhosis. So this is an important case to start with just because of how common cirrhosis is. And also the absence of these findings should present a clue to maybe think about an alternate diagnosis. Let's move to case number 2, a young man presenting with fever and chills. Again, very minimal history here, but done on purpose. So what findings are present here in this image? These are tender and palpable. And again, look at the pattern. They're on the thenar, hypothenar, pads of the fingers, base of the fingers. What are these lesions? And while you're thinking about that, you look at the sole of his foot, and this is what you see. You see these non-palpable, flat, non-tender lesions. And Renato is absolutely right. These are Janeway lesions. Janeway lesions are kind of flat, non-tender. And this is a good example that we should look not just at the patient's hand, but also their feet, because oftentimes a finding may not be present on the hands, it's present on the feet. If we don't look, we're going to miss it. So this patient has Osler nodes. These are Osler nodes and Janeway lesions on the hands and the feet. And so now we're starting to formulate a hypothesis about what could be causing the fever and chills. So of course we go to listen to the patient's heart, and we should anticipate what we might hear when we listen to the heart. Anticipation is so critical in medicine. The ears can't hear what the mind doesn't know. So if you don't go to listen to the heart with already an idea of what you might hear, thinking about the diagnosis that I know you're all thinking about right now, given the Osler's nose and Janeway lesions, think about what type of lesion do these patients develop in the heart involving their valve? Is it a stenotic lesion or is it regurgitant? So we should be listening for a regurgitant murmur. And so this is this is not our patient. This is just a frame of reference to make sure the sound works. This is a normal S1, S2. Mario? So now let's listen to our patient. And we're listening over the apex area, and this is what we hear. So who can describe this murmur? And here it is annotated for us. So when I think about murmurs, the first thing I want to know is it systolic or is it diastolic? What's the shape of it? Is it crescendo, decrescendo? Absolutely. It's a holosystolic murmur. It occurs across all of systole, and it's flat. It's flat in shape. It's a flat sound all the way across. And what valve do you think might be involved here in this case? In this case of endocarditis that I know you're all thinking about. Mitral, exactly. So this patient has mitral valve endocarditis. The story doesn't stop here, though. A couple of days into this patient's hospitalization, his heart sounds changed from what we just heard to this sound. So take a listen to this. Anybody know what that sound is? Close, Renato. Not a click, but it's not a murmur either. So you're close in the sense that it's not a murmur. So it's another sound. Yeah, exactly. This is a pericardial friction rub, and I'll play it again. It's got a kind of a creaking leather, or you think about a wet balloon and rubbing your hand across a wet balloon. Kind of has it's like, it doesn't sound like a murmur. I'll play it one more time here. So now you know that this patient has pericardial involvement of their endocarditis, which is very important to know. And a couple of days after that, after you hear the rub, the patient becomes a little hypotensive and pre-syncopal. The rub goes away entirely and the heart sounds are a little bit more distant. And this is what his neck veins look like. So what's going on here? Yeah, exactly. And the find, just to be explicit, the finding here is elevated jugular venous pressure. Look at the EJ, it's engorged here. He's sitting upright. And so this is absolutely high, very high. His neck veins are engorged. He's become hypotensive. His heart sounds are more distant, and you guys are absolutely right that he has developed tamponade. And so, this is a great example of where the physical exam becomes so important because things evolve on a day-to-day basis, even on an hour-to-hour basis or a minute-to-minute basis. And we rely on our stethoscope in this case to hear that pericardial rub. The astute clinician could have predicted all of this as it was happening and gotten this individual treatment right away with no delay. An ultrasound you can't diagnose acute pericarditis because a lot of times it's dry pericarditis, so it's not associated with an effusion. And if there's no effusion, the ultrasound is totally useless. So we have to hear it with a stethoscope. And so again, this is why a physical exam is so important. This next case involves a young woman who comes in with, actually the way her story goes is she developed pain and swelling over the dorsum of her left foot. And she goes in to see her doctor. They tell her that, it's overused tendonitis, ice it, stay off of it, take some NSAIDs. She does. It eventually gets better a few weeks later. Then she develops pain and swelling involving her left knee. She goes back to the doctor. They say the same thing, ice it, stay off of it. That gets better. Then she develops the same thing in her right knee. So she has a migratory arthritis. She goes into the emergency room because it's not getting better. And there, an orthopedic surgeon does an arthrocentesis and discovers about 10 to 12,000 white cells in her synovial fluid. Presumes that she has septic arthritis. They take her for a washout procedure of the knee. She doesn't get better after that. So what do? They do a second washout procedure of her knee. So now she's had 2 surgical procedures done. And then they transfer her to us. I meet her, and I have, a habit of looking at the hands and the fingernails. And I see this finding. And I don't know what it is when I first see it. I was not familiar with this particular sign. I was actually looking for something else and I saw this. Does anybody happen to know what this is? Yeah, exactly, Gabriel. And I was looking for pitting because nail pitting is usually what you see with psoriasis, but I didn't see that. I saw this and I looked it up. And it turns out that this is also a manifestation of psoriasis. It's called the oil drop sign. And it's really aptly named because it does look like a drop of oil there on the nail. And that's exactly what she had. And so I started to look, exactly, Natalie. So I started to look at other areas of the body, and hidden behind her hairline, I had to pull her hair up, is this, and behind her ear is this. So they were hidden from plain sight. Just took a little bit of extra investigation. And what were these clues here at the crime scene? What are these? What do we call these skin findings, the skin rash here? Yeah, these are scaly erythematous plaques consistent with psoriasis. And so the diagnosis here is psoriatic arthritis. So this patient went through 2 completely unnecessary surgical procedures and suffered for several months without a diagnosis because these signs which were there to be discovered were missed. It took a little bit of extra investigation to look behind the neck, behind the hairline, and at the fingernails. So an important case to highlight. Here's another case of a young woman who's coming in with lightheadedness. And what do you notice? This is my hand next to hers. And what do you notice about her hand here? And in particular, the skin. Yeah, so exactly. So she has maybe it's pale. So what you're noticing is a difference in color here versus the knuckles. So are the knuckles hyperpigmented or is the skin pale relative to the knuckles? And I will tell you that I had the benefit of asking the patient, and this is her normal skin color here. So her knuckles are hyperpigmented. Now here's another individual with the same disease who that's his wife's hand right here. And they estimate, so his skin started to darken about 8 years, over a period of 8 years. And they estimated that his skin tone was similar to his wife's at the start of this. And now he's completely hyperpigmented. And he saw multiple doctors, including a dermatologist, over the period of 8 years, and was not able to learn what his diagnosis was. Nobody was able to make the diagnosis. So back to our patient, she has hyperpigmentation involving her knuckles, and she's coming in with lightheadedness. So what condition should we think about in somebody with lightheadedness who's coming in with hyperpigmentation? Yeah, exactly. Addison's disease. We would say your name Natalie here in America, but I'm guessing you pronounce it Natalie, I would think, but I don't know. Anyway, you're absolutely right. This is Addison's, or primary adrenal insufficiency. And when you get primary adrenal insufficiency, your ACTH levels go up and up and up, and ACTH stimulates the melanocortin-1 receptor in the skin, causing hyperpigmentation. Before it gets to this stage, it starts to involve the areas under high pressure or stress, like the knuckles or the elbows, and then it generalizes. Now, there's one other finding here in this photo that I'm hoping you all can appreciate, involving her fingernails. You might be able to tell. So first of all, what do you notice about the fingernail polish? Do you notice anything? Yeah, so the nail polish doesn't go down all the way, right? So there has been some growth in her nails since she last polished them. And it turns out that nails grow about 1 millimeter per week. So she has about 2 to 3 millimeters of growth. So she stopped doing personal hygiene because she got sick about 2 or 3 weeks ago. So, and that's exactly when she started to feel ill. So the astute clinician can use this clue to figure out roughly when this illness started. And it started in her about 2 to 3 weeks prior. So you already got the diagnosis here of adrenal insufficiency. Nice job. This is a 60-year-old woman coming in with painful hands, and she comes into the emergency room. And what do you notice here? She has clubbing, and you can especially tell on the side image here where she's lost her Levy-Bond angle. So she has clubbing here. And what else is there? Yeah, there's kind of this hypertrophy, this erythema and swelling of her DIP area that's consistent with arthritis there, as well as periostitis. And does anybody know what that triad is known as, where you have clubbing, periostitis, and arthritis? There's a certain condition it's associated with, a certain term. I don't appreciate any cyanosis here. I think there's definitely some erythema. Definitely, there might be a little cyanosis, but it's hard to tell. But that triad there is, yeah, hypertrophic osteoarthropathy. Awesome. So now she wasn't complaining of any respiratory symptoms, but what condition is hypertrophic osteoarthropathy associated with? Exactly, lung cancer. So that prompted us to get lung imaging, And look at that spiculated mass in her lung. She had non-small cell lung cancer, giving rise to the triad of hypertrophic osteoarthropathy, and critical in making the diagnosis in this case. Now, our next patient is also a young man with blurry vision this time. And what about his hands? Yeah, he's got arachnodactyly, spider-like hands. Here's my hand next to his. I can palm a basketball, and so I don't have small hands. He just has very large hands. And so then we look, we're starting to form a hypothesis here about Marfan's. We look in his mouth, and he has what? Yeah, he has a high arched palate, known as an ogival arch. An ogival palate? Well, that comes from an ogival arch, an OG. What is an OG? An OG is an arch that comes up. It doesn't come up to a smooth ceiling like the typical arch like here or here. It comes up and then it comes up again. There's a point up at the top where it arches again. This was a popular form of architecture back in the Gothic era. And when I was in Syria in 2010 visiting family, I went to I took a bunch of pictures, and I was looking through my pictures because there are so many arches in Syria. It's just part of the architecture there. And I was looking through, and I was able to find this example. This is a picture of an arrow slit in an old famous castle in Syria. And you see this arch above it, it's an ogival arch. It comes up, and then it kind of comes up to a point right here. So it peaks again at the top. And this is from this castle in Syria, known in Arabic as El Hussein, known in French as Crac de Chevalier is the name of this castle. It was built in the 1100s. A very famous castle. And here's a image. As I was going through my images, here's a picture of a church inside Syria near where my family's from, and you can see the typical arch here. Here's yet another example of the more typical arch. Here are some Roman ruins from inside Damascus. These are thousands of years old, again showing the typical arch. But that's not what our patient has. He has an ogival arch, an ogival palate. And we're able to put all these findings together to make the diagnosis of Marfan syndrome, as you already have. This is a young man with rapid weight gain over a period of 7 to 8 months. And in his driver's license photo, you'll see what he looked like. This was taken only about a year before. And you can see a square jaw here. And what else do you appreciate here in the photograph? What's happened to his face? Yeah, he's got moon facies. So he has adipose deposition, but in a certain pattern. So his face has become rounded to the point where we can no longer see his ears on a straight on view. In this image, you can clearly see his ears here, and we can no longer see them. So he's put on a lot of fat around his face. What else do you notice about his forehead area? Is there any other finding there that could be a clue? Acne. Yeah, exactly. You look at his abdomen and his neck area, and what are these findings? Yeah, striae as well as a buffalo hump. And we're able to put this all together to make the diagnosis of Cushing syndrome. Exactly. This patient went 8 months with this rapid weight gain, with these findings, and he was told that he was just simply gaining weight and that he needed to work on his diet and exercise. He saw his physicians multiple times over that period. Why am I gaining all this weight? Oh, you just need a diet and exercise. And these findings were right there, waiting to be discovered, and were not discovered. We're about a little over halfway through here. This is a cousin of mine, actually. He was 37 at the time, and he presented kind of similar as the psoriatic arthritis patient, where he developed pain in his right knee, pain and swelling in his right knee, atraumatic, no trauma. And it lasted for a few weeks. It got better. Then he got pain and swelling of his right shoulder. That lasted a few weeks. It got better. Then his left knee became involved. And he had seen several physicians about this. He got both of his knees MRI, and of course MRI was totally negative. And he was also complaining of pain in his mouth. And so what finding is present here? What is this right here? Yeah, so I'm not sure we can call it a granulomatous ulcer at this point, but definitely an ulcer, an aphthous ulcer. Yeah, oral ulcers. So now we have a young man with migratory arthritis and oral ulcers, and he's Syrian. I told you I'm Syrian. He's my cousin. He's also Syrian. So what condition should we think about in this case? You can think about lupus, definitely. Behçet's syndrome, absolutely. Behçet's disease. It's known as a Silk Road disease. So it affects individuals from along the Silk Road, and of which Syria is part of. So you should think about that. He did not have any genital ulcers, and he did not end up having Behçet's disease, but a great thought. So seronegative spondyloarthropathy, absolutely. So what are those? What are some that you can think of? And I'll tell you, with that kind of in mind, he did have a diarrheal illness that preceded his symptoms. So is there one particular type of seronegative spondyloarthropathy that you would think about in somebody who had a diarrheal illness? You could think about IBD, so absolutely. There's another one where his abdominal, he didn't really have, it was pretty transient. It lasted a few days. It went away on its own. So maybe not as consistent with inflammatory bowel disease, although that's absolutely on the differential here. Reactive arthritis, and that's what he ended up having. You could also think about things like familial Mediterranean fever, especially given his ancestry, but he did not have that. He had reactive arthritis. And, most patients with reactive arthritis, it resolves over a period of a few months on its own, but some, about 10% of the time, it persists beyond 6 months, and that's known as chronic reactive arthritis. And unfortunately, that's what he developed. So he needed to go on immunosuppressive medications, and he ended up, going into remission. And this is here I am in his living room, draining his knee effusion before his meds kicked in. And by the way, he's a lawyer. So I was performing a medical procedure in a lawyer's living room while his wife was taking pictures of me doing it. I don't recommend that. But thankfully, the procedure went well. Here we are. We're both happy. He had his effusion drained. I have my sample of fluid there. So he had reactive arthritis. This next case may be familiar to you. I might have talked to you about this case before, but it's a gentleman coming in with shortness of breath, and he actually had the clinical syndrome of heart failure. He had elevated JVP, he had orthopnea, PND, and here are his vital signs. And what stands out to you about the vital signs here? Yeah, he's got a wide pulse pressure. The difference between the systolic pressure and diastolic pressure is large. And so what condition do you think about, when you see a wide pulse pressure? At least for me, it's my knee-jerk response. I think about this valve condition every time I see a wide pulse pressure. Aortic regurgitation, absolutely. So that's what I was thinking about too. So I looked at his fingernails, and this is a movie of his fingernails. And what finding do you notice here that go along with aortic insufficiency? His Quincke's pulse. So he has a pulsating nail bed. I hope you can all appreciate that. And so I look at his neck, and I'm expecting to see a bounding arterial pulse, which is exactly what I see, known as Corrigan's pulse. So I'm thinking, oh, this is definitely aortic insufficiency. But what if I told you that he did not have a diastolic murmur on exam, and the echocardiogram showed a totally normal aortic valve and was in fact otherwise completely normal echo? Well, it turns out that these findings are not specific for aortic regurgitation. They are simply findings of high output physiology or hyperkinetic state from any cause. And so now we have a gentleman coming in with heart failure, with syndrome of heart failure, and evidence of high output physiology. So what diagnosis should we consider? Most patients with heart failure have low output. Their cardiac output is low, but some of them have high output, and that's known as high output heart failure. And so we went ahead and got a right heart cath on this procedure, and his cardiac output was 13 liters per minute, which is almost 3 times normal. So confirming the diagnosis of high output heart failure. But that's kind of a diagnosis like anemia, where, yeah, you can diagnose anemia, but you have to know what's causing the anemia. So you all are getting into that right now, which is, what are the causes of output heart failure? Severe anemia, wet beriberi, which is thiamine deficiency, thyrotoxicosis, arteriovenous fistula, so left to right shunts. Of course, all of those are absolutely correct. And in this case, I got some more history, and he was drinking a lot of alcohol. So I checked the thiamine level, it's very low, confirming the diagnosis of wet beriberi. And this is a really important case to highlight, because I would think most clinicians would, this patient would get diagnosed with heart failure. He would have a totally normal echocardiogram, and he would be told, you have this condition called heart failure with preserved systolic function. We see it all the time. We diagnose it all the time. We're not sure why you have it, but you do. Here are some diuretics. You'll get better with these diuretics. And he would have been on diuretics his whole life. The observation of the wide pulse pressure and the Quincke's pulse and the Corrigan's pulse allowed for the diagnosis of wet beriberi. Why is that so important? It's treatable. Look at his pulse pressure over time with alcohol cessation and thiamine replacement. Blue is systolic pressure, orange is diastolic, green is the pulse pressure, and look at it drop all the way down. And he was cured, no longer needed diuretics, and was cured of his heart failure. This next case is something we like to call an Augenblick diagnosis, which is German for blink of the eye. So this is a diagnosis that you can make in the blink of the eye right at the bedside. And so let me play the video here for you. So a lot of people, when they saw this patient, in fact, all the providers who saw the patient thought that this was an arterial pulse, because it has a single peak and a single, it's a single peak. And while that's true, this is unmistakably venous. Look how diffuse it is. While the outward wave is impressive, the inward collapse is even more impressive. Exactly, it collapses, which is telltale sign of a venous pulse. This is venous. And this is a certain sign that can tell you what's going on in the patient's heart right then and there. Here's another patient with the same condition. And in addition to this finding in the neck, what else do you notice or appreciate about her? What's going on with her face or her head if you just look at it? Yeah, and it's moving. She has what's known as a head bob. And it's not a to and fro head bob like this, like you'd expect with aortic regurgitation. It's called Demusset sign. This is a side to side head bob, lateral head bob. And that's because as this bolus of blood goes up into her neck, it's causing her head to tilt side to side. So what do these patients have? What is the condition here? This is Lancisi sign, side to side head bob. This is tricuspid regurgitation. Diagnosis you can make just like that in 2 seconds at the bedside. Nicely done. So we're almost done here. We've got a couple more cases. Here's a man who I saw was actually working on the procedure service at the time. This was just a few months ago. And we were asked to do a paracentesis. And so we go in, and I could not help but notice what I'm sure you're noticing. What are these engorged veins on the side of his head? And in fact, when he turned his head over, you could see engorged veins pretty much everywhere throughout his entire head. And so and here's the video associated with that. So you can see engorged veins here. You can see the EJ right here. Look at that. It looks like a hose. So, and he's sitting upright. So he's got markedly elevated, what looks like elevated pressures here. I turned to his wife and I said, have you noticed these veins before? She said, I did notice, and they started about 3 or 4 months ago. And he was a cancer patient. He had cancer. So he was seeing oncologists regularly. And she asked all of his oncologists, what are these? What's causing them? And she said, not only could they not tell her what was causing them, but they didn't seem interested in her question. They were dismissive of it. Well, I was surprised to hear that, because what could present this way? What related to cancer, for example? And maybe related to the treatment for his cancer. What could present with markedly elevated central venous pressure? Could be superior vena cava syndrome or SVC syndrome. That's awesome. That's a great thought. That's what surprised me. How could his oncologist not be interested in this? This is a sign of SVC syndrome. Turned out that's not what he had. He had a right heart cath done, and his right atrial pressure was 31 millimeters of mercury, which is about 42 centimeters of water. So he ended up having heart failure from the chemo, which again, the oncologist should be aware of, should be interested in. He went months without a diagnosis, and when it was right there, staring them in the face. And it's, kind of a shame how we've moved, at least here in America, we have moved away from the basics of medicine, and everybody knows how to order a cardiac MRI on their patient, but they don't know how to look at the neck veins. And here's a sad situation where this patient suffered unnecessarily for several months. This is one of my favorite cases here. And this is one where I failed, but I learned a lot from this case. So here's a 44-year-old man with shortness of breath. And he actually spent a week in the hospital before I met him. He was in the cardiac ICU. He came in with cardiogenic shock. And they diuresed him. They had him on inotropes. They got him through it. They stabilized him. And then they sent him out to the floor where I was taking care of him. And I met him. And this is the day that I met him. And this is what I see. So you can see a venous pulse over here with the inward collapse. But these other pulsations here are arterial pulses. So that catches my eye. And I think to myself, could he have aortic insufficiency? So I look at his fingernail, and of course it's blinking because he has Quincke's pulse. And so I think this could be aortic insufficiency. He's been here for a week. I'm sure they got multiple echoes. I look, he does have aortic insufficiency, but it's only mild. It's not enough to explain these findings. So then I think, could he be like the other guy? Could he have high output heart failure? Well, that'd be a great diagnosis to make. And so I talked to the cardiology team about it, and they say, okay, he's going to have a cardiac MRI tomorrow, and it would show evidence of high output physiology if he has it. So I said, okay. So I stopped thinking about it, and I went about my business. The next day, he got a cardiac MRI. It did not show high output physiology, but it did show the diagnosis. And when I got the diagnosis, I went back to the bedside, and I felt his radial pulse and I felt his femoral pulse, and they were not occurring at the same time. And I recorded it with a Doppler machine. So take a listen. So those are discordant. Listen to his radial pulses. These occur at the same time. This serves as a nice control. Once again, the radial femoral pulse. So what does this patient have that I should have been able to diagnose? Coarctation of the aorta. Nicely done. I had everything I needed to make this diagnosis, and I failed to do so. But I learned from this case, because now coarctation is on my differential for when I see Quincke's pulse or Corrigan's pulse or signs of high output, because what happens is the lesion's in the aorta. So everything proximal to that lesion gets a lot of the cardiac output. So the pulses are bounding, and everything distal to that coarctation is weak and delayed. So this was a case of coarctation. Now, this man was 44 years old, and this is a congenital problem. So he went all of his life without a diagnosis. His clinicians failed to pick up the findings, just like I did. And so hopefully we can start to pick these things up earlier. By the way, here's his chest X-ray showing the rib notching, which is characteristic of coarctation of the aorta. He had 12 chest X-rays done. None of them mentioned anything about rib notching, and this is only discovered in retrospect. This is a quick one. It's a young woman who presented with acute epiglottitis with H. flu bacteremia. And a couple days into her hospitalization, she developed abdominal pain and was diagnosed with acute pancreatitis. And then she was transferred to our institution. And when I'm getting sign out on the, I'm about to start the next day. So I'm hearing about this patient, and we're talking about how weird this is, with the other doctor who's been taking care of her. This is strange. How could a young woman come in with epiglottitis and also develop acute pancreatitis? That's something seems weird. We start Googling any association between epiglottitis or H. flu bacteremia and pancreatitis. Can it cause it? The answer is no. And so, or at least we couldn't uncover anything. So this is strange. So the next day I walk in to meet her, and this is what I see. Now her lips look a little bit reddish and they're a little bit chapped. That's not the finding I'm interested in. So what finding did I see here where it was almost like an Augenblick moment where I said, I think I know what might be going on here. So good thought, because there is a little bit of swelling of her cheeks. And it sort of has that chipmunk appearance, but it's not the most. There might be a little swelling. What else is on her cheeks? And maybe the bridge of her nose. Yeah, there's erythema, and it's in this butterfly distribution, a Malar distribution, where it spares the nasolabial folds. So I see this, and then I started asking her some retrospective history. Turns out we thought she was previously healthy. She'd been having joint pain and morning stiffness for the last year or so, and her titers were sky high when we tested her for lupus. And it turns out that about 10% of patients with lupus develop pancreatic involvement, so they get inflammation of the pancreas, and so that's exactly what she was diagnosed with. 2 more cases for you all. So here's a woman coming in with dyspnea, and you start with her hands, and what do you notice on her hands? Particularly her skin. What are those little red spots? Yeah, you think about telangiectasia. So you want to know, do they blanch and fill like a telangiectasia would? So you press on them, and look at that. They fill just like a telangiectasia, which is exactly what these are. So what conditions would you be thinking about at this point? Start to formulate maybe a hypothesis, and you think about CREST syndrome. You ask her to make the universal sign of prayer to bring her hands together. She cannot do it. There's a gap in between her hands because her skin is so tight that she can't straighten them out. And so you're thinking about sclerodactyly here, and you're thinking about CREST syndrome. So you look at her other parts of her body, you ask her about any hard nodules. She says, as a matter of fact, on my elbow, I've got this white hard nodule. You look at that and you see that there, and you're thinking to yourself, this could very well be scleroderma or systemic sclerosis, CREST syndrome, but why is she dyspneic? So you take a look at her neck.
And take a slow breath in like you did before. That's it. And out. And in.
Yeah, so what finding is present in this video? Yeah, so you're seeing Kussmaul sign that's rising when she breathes in. And so you're thinking, could she have pulmonary hypertension related to this diagnosis of scleroderma? Could she have? Is that what she could have? So you listen to her heart with that in mind, and here's what you hear. So there's a very loud S2 here, and they're split. S2 is split into A2 and P2. And P2 here is louder than A2, which is consistent with pulmonary hypertension. And then there was a question about W sign in this video. I didn't appreciate that, but let me look again. The normal jugular venous pulse, the X and Y troughs are conspicuous. They're easy to see. And so I can see why you would think that, especially when there's that dynamic when she's breathing in. But it's a little bit harder to assess the waveform when the patient's breathing in or out. It can kind of exaggerate the waveform a little bit. So I can see why you would think that this is the W sign. And I don't think she has it, but it's a great thought and a great observation, because when she breathes in, the X and Y, they do become much more obvious. But they're still within normal, I would say. But you all are absolutely right that this is a diagnosis of CREST syndrome, scleroderma, systemic sclerosis, and she has pulmonary hypertension. Well done. All right, let's go to the last case here. A young woman who comes in with sort of transient right-sided weakness and dysarthria, difficulty speaking. She goes to the emergency room. They document her exam as normal. Her symptoms have resolved by the time they see her. They send her home without a clear diagnosis. And then 2 days later, she shows up with severe flank pain. They document her exam this time with a subtle murmur, but no further explanation. They get a CT of her abdomen out of concern for appendicitis. The CT abdomen doesn't show appendicitis, but it does show complete occlusion of her right renal artery. So her left kidney has contrast throughout it, but the right kidney does not, indicating that there's an occlusion there. So they take her for an embolectomy procedure, which is successful, but shortly thereafter, she develops hemoptysis, hypoxemia. They are concerned for PE, so they initiate a thrombophilia workup. Lots of different labs are sent off. They get a CTA of her chest out of concern for PE. The CTA of her chest does not show a PE, but it does show bilateral ground glass opacities. They get a bronchoscopy at that point. It confirms the presence of blood in her alveolar space. Somewhere along the way, they get an echocardiogram, and it reveals the diagnosis. And she went through all of this, and there was a finding that would have sealed the diagnosis before any of this happened, the first time she presented. And this is what her heart sounded like if they had just listened. Now, there's a lot going on in this phonocardiogram and in this audio clip. Does anybody have a clue? I'll show you the annotated version next, but anybody know what this is? So good thought with the tumor plop, but no, not a tumor plop. Although there is an extra sound near S2, which is why I think you would think that it's a tumor plop. So there's a differential with extra sounds near S2. And this is for frame of reference. This is S1 here. The loudest sound is S1. This is systole, which is relatively quiet. There's S2 here. Then there's this extra sound, which I think is what you were thinking was a tumor plop. But there's another differential there. You know, the S3 is in that differential. Split S2 is in that differential. Tumor plops in differential. Pericardial knock is in that differential. There's one other thing that's in that differential. So close to mitral regurg, but if it wasn't regurg, what's the other lesion that you could get with a mitral valve? Mitral stenosis, and that's associated with an opening snap, and that's what you thought was a tumor plop. So let's play this again with this annotation in mind. So you have a very loud S1, which is consistent with mitral stenosis. You have a quiet systole. You have S2, an opening snap, then a rumbling diastolic murmur that gets louder right before S1. It's a crescendo, decrescendo, crescendo murmur, right? Crescendo's at the end because that's when you have atrial kick. So when the atrium is squeezing against a stenotic valve, it creates high pressure and more turbulence. So let's listen. So this patient has mitral stenosis. And why did she present the way she did with TIA and with a renal artery embolism? Well, we all are familiar with the term valvular AFib. Most people think that just means any valve problem plus AFib, not so. It specifically refers to mitral stenosis and atrial fibrillation. Why? Because these patients are extremely hypercoagulable and are very prone to cardioembolic events, which is exactly how she presented with TIA and then with a right renal artery embolism. And that history, plus she grew up in Mexico, where rheumatic heart disease is still prevalent. And all they had to do was listen, and they would have heard this classic symphony of mitral stenosis in her heart, and would have been able to make the diagnosis a lot sooner. That's the talk. I hope you all enjoyed it. And I hope it illustrates, again, how powerful the physical examination can be. It was so powerful for these patients. It will be powerful for your patients. I promise you, patients will be saved unnecessary suffering and cost of unnecessary testing if we pay very careful attention to the history in the exam. Thank you again for having me. I'm happy to hang out, chat, answer questions, whatever you'd like.
Well, thank you very much, Dr. Masur. I think it's been a a really enriching hour for everyone. I just wanted to plug in. I remember I bought your framework for internal medicine back in, I think, in 2019, way before the pandemic, and it really was the first time I was exposed to the frameworks system of thinking actually. So I would encourage anyone here in the audience to really get the book. It's really an amazing book, and also the physical diagnosis website. That's been also a very great learning tool. It's just an amazing resource. And if there's someone in the audience or chat that wants to ask a question, maybe this would be the time.
Thank you for the kind words, Mario. I really appreciate that. Really appreciate it. The book's actually available now. There's a Spanish version as well. So I know a lot of my colleagues have gotten the Spanish version in addition to the English version, because we're always trying to learn medical Spanish, and it's having an English version and a Spanish version of the same text can be very helpful for that. And I'm sure you all are always trying to become better at medical English, and it can be very helpful for that reason too. But yeah, happy to take on any questions or comments.
Maybe I can ask a question.
Sure.
I think there's a lot of emphasis, especially in these times of pandemic for us, that the clinical reasoning part is really focused on having the information and trying to figure out what's happening, but not acquiring the information. And I think you put a lot of emphasis on that first part. What recommendations or tips would you give us, or would you give medical students that want to improve in that area of their training?
Well, thank you for asking that question, Mario. It's a great question, and you're absolutely right. I always harp on the fact that we take standardized tests in medicine. That's how we test and pass and get our license and all that. And a lot of people think, students and residents and doctors, they think that if they do well on their standardized tests, USMLE and the boards and all that, that they're going to be great doctors. Well, I have news for them. That is not true. That is not true. It's great to pass your boards and do well on them and ace them and all that. Absolutely. That's only one out of the 3 steps that you need to make a diagnosis. These standardized tests, they give you all the clues, as you mentioned, Mario. So we have all the clues that we need, all the important pieces of information. And all we need to do is synthesize those clues to make a diagnosis. But that's only one step. That's the final step. Steps 1 and 2 in the diagnostic process are knowing what information is important to acquire. And that we do that by formulating hypotheses, so that when we see those Osler nodes in this guy presenting with fever, and we see the Janeway lesions, we know, hey, we're thinking about endocarditis. So then that tells us we need to acquire a lung exam or a heart exam. We need to acquire the history. Is he using IV drugs? Does he have risk factors? Any dental procedures? A prosthetic heart valve? That tells us what information we need to go and gather. Then, of course, we have to have the skills. That's step 1. Then having the skills to acquire that information is step 2. It's not enough to know that it's important to listen to the heart. We have to have the skills to listen and hear that holosystolic murmur and say that's consistent with mitral valve endocarditis, mitral valve regurgitation from mitral valve endocarditis. So that is so true, Mario. 1, 2, 3. You cannot just synthesize, because patients, again, don't show up saying, I have a holosystolic murmur. I use IV drugs. We have to acquire that information, and we have to do so at the bedside. Now, that's just reiterating what you already said. To answer your real question, which is how can we be better at that? Well, the first step is just to recognize that as you have to come to terms with that if I do well on a standardized test or my boards, that doesn't mean I'm going to be a great clinician. I have to be a great clinician, I have to acquire the clues, just like the detective at the crime scene. You could have 10 different detectives evaluate the same exact crime scene, and the better detectives are going to glean important clues and pieces of information that others gloss over or miss. Same is true in medicine. So first of all, recognizing that. Now, most of this is the history, to be fair. I'm big on physical exam, but a lot of it's the history. Probably 85% of it's the history. The other next 10% is the exam, but they both go hand in hand. But we have to recognize how important it is, and we have to stop relying on technology and ordering all these tests. That comes at a high cost to patients. But we have to spend time formulating hypotheses. So that's step one, Mario, to answer your question is when we see a patient, we should look at a framework or we should build a framework for ourselves. And then that gives us a collection of hypotheses that we can then go back and test. So when pulmonary embolism shows up on that differential, now tells us we need to go back and ask the patient, have you had any injury to your leg? Have you had any long plane flights? Do you have a history of clotting? How about your family? And on exam, it tells us that we need to look for signs of a DVT. We need to listen for evidence of pulmonary hypertension, a loud P2, feel for an RV heave, look at the JVP. So it tells us what information we need to go gather, having that collection of hypotheses. So the framework system is really helpful for that. And then, becoming better at the exam and picking up things is a matter of spending time on the website, hopefully being exposed to these different murmurs and these different findings will allow you to be able to recognize them when you see them. And then having a mentor, somebody in the hospital, I'm sure, in fact, last time I spent time with you all, there were several such individuals who have a lot of experience. And when you see something or you think I'm hearing an S3 or I'm hearing a holosystolic murmur, page them, call them, say, hey, could you come to the bedside and listen and tell me, even if it's just, Mario and Renato, just come to the bedside and, hey, what do you hear? What I hear, what do you hear? And having a second set of ears there will allow you to hone your skills and become better at the exam. And when you do have the benefit of an echocardiogram telling you that the patient has severe aortic insufficiency, use that information, go to the bedside, listen for that diastolic murmur, feel the water hammer pulse, look for the Corrigan's pulse, look for the Quincke's. That will allow you to calibrate your exam so that next time you see these things, you'll be able to recognize them. So that I know I said a lot there, but that would be where I would focus on in terms of knowing, how to acquire these clues at the bedside and becoming better at it.
That was great advice. I think most of us, as I'm sure everyone here is really a dedicated student. Sometimes we tend to orient our studying to what's going to help us on the tests, and the part of information acquisition is not really, you don't get tested on that. So to recognize that, I think it's extremely important. So if no one else has any comments, I think everyone is awestruck from the great presentation. I just wanted to really thank Dr. Mansour for really taking out of his very valuable time to share these great teaching points and information with us. And hopefully we can do this again. It's really a great time. Thank you very much.
Anytime. I'd be happy to come back and talk about anything and chat with you all some more. I appreciate you having me. And if there's no questions, I'll put my email is right there on the slide. So, if you all want to email me or get a hold of me on Twitter or whatever, happy to talk anytime. And Mario, I noticed that this was recorded. You're very welcome. Mario, I noticed this was recorded. If you could send me the recording, that'd be great. I'll probably use it for educational purposes, maybe put it on YouTube as long as you all are okay with that. This is, like I said, I think the second or third time I've given this talk, so I don't have a recording of it, so that'd be helpful. You're very welcome. You're very, very welcome. Thank you for having me, and thank you for spending your evening listening to this talk. I hope that it will change your approach or reinforce the approach that you're already taking.
Perfect. Thank you, Doctor.
Thank you. Thank you, Dr. Mansour.
Yeah, of course. Have a great night, everyone. Thanks again, Mario. Renato, thank you for having me. I really appreciate it.
Bye. Have a nice evening.
Bye.